This PowerPoint is on the pain exemplars, and I'd just like to review a little bit something about the WHO ladder. I said usually we start pain medications at the bottom with level 1, but in actuality sometimes we start at the highest level when the pain is very severe. So usually mild pain we start at the bottom, moderate pain it might start in the middle, and severe pain start at the top. The first exemplar is chronic osteoarthritis pain. So bone-on-bone pain is caused by osteoarthritis. This often occurs in the knees. You can see in the picture where the bones are rubbing on each other. This is diagnosed by an x-ray. It leads to chronic pain and mobility problems, obviously. And some days it's worse and some days it's better. Often people will need joint replacement because of it. And usually non-pharmacologic measures will ease the pain, but sometimes patients need to take NSAIDs, but rarely are they given opioids for this pain. If you would like to get an idea of what pain is like for different people, on different circumstances, I would suggest that you go through and click on these videos. There's 3 of them. One is a young man with sickle cell anemia, which causes pain because the blood vessels narrow and the oxygen is cut off to organs and to the limbs. And so oxygen therapy and fluids to open up those blood vessels, that's the treatment, and along with a strong opioid because the pain is severe. The picture in the right hand corner, that's Miss Lucy, and if you see her in this video, she's having severe pain, so you can compare that to the mild pain that she had. And then in the right lower hand corner is an infant who we know is having pain because this is a procedural type of pain, but the patient is unable to move. You can't look at their face or their arms or legs to see how much pain they're in, so it's very challenging. We can look at the vital signs, and we're going to treat this patient for pain even though we don't have their obvious behavioral signs that they're having pain. The next exemplar is surgical pain. So when we're talking about surgical pain, it varies from individual to individual. Some people tolerate pain so well that they hardly need any medication. Other people don't want to experience any pain, and they're very sensitive to slight movements, etc. Patients need education about pain medication, so patients can have surgery. They need to be told, well, this is what you can expect for pain after the surgery. This is your choice of medications, and they can determine what they would like for pain medication. We have to discuss the risks and benefits. That means our patients are well informed, so they can make informed decisions. We offer options based on what is ordered by the physician. So usually what is ordered is a basket full of medications. You pick which one is going to work best based on the patient, what they say their needs are. Now sometimes when a patient just initially comes out of surgery, the surgeon will say, give opioids, schedule opioids, and give those opioids early. But then gradually they'll be weaned down to oral medications before they get discharged. So parenteral medications are IV administration. Local means a patch, like a lidocaine patch, which is very, very common for pain. They also might use a nerve block during the surgery, and sometimes it's left in after the surgery, and it goes usually directly into a joint or into the nerve. So post-operative management includes different types of pain and different routes of delivery systems because this depends totally on the surgeon's preference. Medications can go directly into the nerves, but that has high risks. Medications can be given as a patch, like a Duragesic fentanyl patch. And that usually works well for pain, but it takes a few days before it works. OxyContin is a common post-surgical pain. It's a long-acting opioid. It does have a high street value, so we guard it carefully and make sure we don't drop it on the floor before we give it. On the patient-controlled analgesia, you watch the video. The patient presses the button themselves. We don't let family members or friends press the button. We don't press the button for them. It's patient-controlled analgesia. And usually it's a strong medication like hydromorphone, which is step 3 pain medication. Here's a case study. Let's look at this. 79-year-old woman with a head of femur fracture for which she had an open reduction internal fixation. That means she had hip replacement or she had screws to put things back together. She's been in physical therapy, but finds that her pain and anxiety prevent her from following the instructions given by the physical therapist. She continues to take her oral opioid on an as-needed basis and feels she cannot function without it. Her physical therapist suggests that she look into non-pharmacologic methods of pain management, including improving her spiritual health. Today she's having a follow-up with the orthopedic surgeon. She asks you, the office nurse, for advice on what she should do for pain. The surgeon wants her to discontinue the opioid medication immediately. So why would the surgeon want her to discontinue the opioid medication immediately? Consider the length of time that it's been since her surgery, because gradually we wean people off from those medications. They can't stay on them forever post-surgically, only if they have a chronic pain. So there are some side effects that come with taking oral opioids, so I hope you're thinking about all those side effects like constipation, some side effects like dry mouth or itching. But she says she can't function without it. Perhaps it's psychological, that she feels like she needs it because she's afraid of harming herself or something with movement. So here now it's time for you to explore those non-pharmacologic methods of pain management, because those things will benefit. She has control over those things. She could use heat, cold, it could be medications that she takes over the counter even too. That's pharmacologic still, but there are relaxation techniques. There's a lot of things that she could try, but she probably has no idea about. Maybe even exercise might help her. Here I would like you to consider what the most appropriate therapy is. For patients with surgical pain that occurs immediately after surgery obviously is going to require a strong opioid, especially if it's abdominal surgery or joint surgery. Additionally, the patient may need positioning or splinting and the use of heat or cold. It may help if you added relaxation and guided imagery in there. But gradually, as the patient gets closer to discharge, we switch them over to weaker opioids and maybe even NSAIDs. We want them to be able to be free of pain and still be able to move. So the use of pain medication is really important. Osteoarthritis, application of heat or cold may work. Positioning might work. There might be some swelling like in a knee associated with osteoarthritis. Guided imagery, perhaps, but usually this is pain that's associated with movement. And NSAIDs work really well for osteoarthritis pain. If needed, the patient might be given a weak opioid while they're waiting to have a joint replacement, for example. But I cannot imagine a circumstance that someone would need a strong opioid for osteoarthritis. This ends the PowerPoints for pain, and now you can move on to the next activity.